Good evening, ladies and gentlemen. My name is Russ Thomas, and I'm the CEO of the Prostate Forum of Orange County. It is our pleasure tonight to bring to you one of the highly regarded speakers that we provide for your information pleasure the fourth Thursday of every month.
They're going to make the risk for cancer or cancer progression greater. There are certain medications that can help hinder prostate cancer, which include cholesterol medications, statins, metformin, which is a diabetic drug to lower sugar, aspirin, and then another group of medications which you've probably heard of called Proscar or Avodar, which are weak anti-cancer agents and that help shrink the prostate. So again, part of the key, early detection is still paramount. So we always talk about PSA testing, digital rectal examinations, and what I'm going to talk about tonight is, are there other blood tests that can be added besides seeing your doctor, doing a PSA, doing a prostate exam? What else can we do? So, and this is just a background in terms of the actual prostate cancer in general. What people don't realize is that a lot of people have no symptoms when they have prostate cancer, whether they're locally advanced or regionally advanced. These terms just mean basically coming outside the prostate or even getting into the lymph nodes. So most men have no symptoms until they're advanced or widespread. When they get bone pain or difficulty urinating, fatigue, a lot of weight loss for no reason at all, these are kind of the warning flags that we worry about. But unfortunately, this is more when they're widespread. So this is just kind of a natural history as far as what we used to get prior to PSA coming into shape in the 1980s. Most men came advanced versus post-PSA. You can see that a lot of people are 80% localized, more curable. But the question is there something else we can do besides just PSA? So part of this is the controversy around the U.S. Preventive Task Force, which in 2012 basically was recommending that men shouldn't get PSA testing over the age of 75. They claimed that it took 1,000 men to be screened to save one additional life. They said that there was too much cost, morbidity, complications, biopsies cause problems, and bleeding and infections. So they said that it doesn't warrant doing PSA screening in men over the age of 75. So part of the background is most men that do get diagnosed with prostate cancer, it's an early type of slow-growing cancer. And what we see in clinic is quite the opposite. But generally speaking in the population, most men have a slow-growing type of cancer. Most men don't even know they have that cancer. So most men, in terms of the U.S. Task Force, they're saying most men are being over-treated. They don't need treatment. They're getting diagnosed with a Gleason 6 prostate cancer, and they're getting booked for surgery the next week. And this is where all the problems come in, that come to this controversy of PSA screening. So what's the goal? The goal in this aspect is to be able to distinguish between benign, slow-growing cancers versus those that are going to get the ability to move and spread and become metastatic and lower survival in the long run. But how do we do this? So tonight, I'm going to talk a little bit about the genomic testing that we use, which are different blood tests that are commonly used. I'm going to focus more on the top three of these: PHI, which is called the Prostate Health Index, 4K score, and another test called Exosome DX. This one just came out this year. There's a couple more I'm not going to be talking about tonight. You may have heard of. One's called the Michigan Prostate Score, and the last one's called PCA3, which I'm sure many of you know of, which we use for years. So the first test, which is called Prostate Health Index, this is a blood test. So this is a test that can be done for patients who are suspicious about potentially having cancer, but want to know more before they do imaging or do a biopsy. So this is a very simple, non-invasive blood test. It's much more specific, at least 3 times smarter than doing a PSA. And this is a tool that we use to ensure that patients don't get biopsied that don't need a biopsy. So again, you look at patients, what their risk factors are, what their PSA test was, then you think of, can I do this extra blood test? That will give me an idea if they need to do imaging or biopsy, as far as the most kind of aggressive screening process. So on the left hand of this graph, you can kind of see these are the scores that come out of this blood test. Men that have low scores, meaning less than 27, have less than 10% chance of having prostate cancer. So this is a blood test that basically estimates what's the chance that you or I or the next guy off the street may have prostate cancer and not know it. And they're screening for what they call clinically significant prostate cancer, or Gleason 7 or higher. So it's not just any prostate cancer. So it differentiates between Gleason 6 or higher. So the next test, which is similar, is another blood test called the 4K score. This is a test that's meant for men who have a high PSA, meant for men that may have an abnormal prostate examination with a finger, meant for men that have had biopsies before that have been negative and are still worried that they may have cancer. So then they do this blood test, and then they get an estimate, which I'll go over kind of a sample kind of score with you. And then that estimate tells the patients, do we need to do more investigations? Do we need to image the patient? Do we need to do MRI? Do we need to do biopsies? What do we do next? So this score is a blood test that takes all 4 of these factors into account. PSA, which is the obvious factor, different forms of the PSA, a free PSA, intact PSA, and then a different protein, which is a lot more sensitive than PSA for screening for prostate cancer. So again, they take into account for people that do this blood test, they look at the patient's age, their previous prostate examinations, if they had previous biopsies that were negative, all these get accounted for and put into a formula to give a result. So the people that benefit the most from this are those that are reluctant about running off and having a biopsy. They just want to get more information. Again, it provides patient-specific probability of having a high-grade Gleason 7 or higher cancer, and it provides a score anywhere from less than 1% all the way up to close to 100%. So this is kind of a sample of one of the patients that I've had run that had this kind of score. Again, the scale all the way from almost 0 to 100. His score came back at 14%, and this estimates that about 1 in 7 men with this score may have prostate cancer on more detection and biopsies. So this gives them some idea of where you sit in the schematic of things. In general, per the company, a low score is defined as a score less than 7.5%. So this is more of an intermediate type score. But again, this is just meant to give more data and how to proceed to the next level of investigations. This test, which is called ExoDX, this is a urine test that came out this year, this January. It's the first and only molecular test to rule out high-grade prostate cancer. So this is a simple urine test. Unlike the PCA3, you don't need a prostate exam with a finger prior to this urine test, so you could just simply give a urine sample, and then you'll get a score from this. So this is a clinically validated, non-digital rectal exam, urine-based test that will give you an estimate. What's the chance that you have Gleason 7 or higher for men over 50, and PSAs in the 2 to 10 range that are considering biopsy. The results, you get a score between 0 and 30. Scores over 10 predict Gleason 7 or higher. And again, it's a very accurate test, so if it's negative or you have a low score, you have a very high chance of not having any kind of cancer. So again, this is one of the most recent tests approved for this indication. Now, I'm going to switch around a little bit for those who already have a biopsy-proven prostate cancer, and they want to know if they may be fit to watch their cancer. There's a few different tests on the market that are genetic tests, one called Polaris, one called Untitled, and then a third called Decipher. So these are all tests that are run on patients' biopsies that are saved. They don't need to re-biopsy, and they look at the genes within the DNA for these actual biopsy samples. So the first one, Polaris, again, this is a test done on the actual biopsy specimens. It provides patients with a risk mortality from prostate cancer. It basically gives you a schematic as to, with your genetics on the actual biopsy, what's the chance that if you do nothing at all, that you're going to end up dying of prostate cancer in the next 10 years. So it gives you some visual data as to how aggressive that this might be. It does a whole panel of about 31 different genes, and it gives you these kind of estimates. It assigns you what's called a cell cycle progression score. And I'll show you kind of an example of this. These are all the genes, not that you need to know these, but this is all the panel of genes that they run. And it gives you, this is an example of a patient score. So this gentleman I had who had a Gleason 3 plus 4, he had a Gleason 7. It ran the genetic analysis on this biopsy, and it said this is consistent with an intermediate risk cancer. So some of the patients come back lower, and that gives them more reassurance. They can be intermediate risk, and actually genetics look more favorable. These guys can look at surveillance. And you can see on the right side of this schematic that this gentleman, at 10 years out, the chance of him dying of prostate cancer doing nothing is about 2%, which is a pretty low percentage. So that all these get factored in for patients that are motivated for surveillance despite maybe having a Gleason 7 prostate cancer. So the second test is called Oncotype. This is a test that's been around a long time for women with breast cancer and then developed in men with prostate cancer. Again, this is another tool to risk stratify patients and how they look as far as the genes in the biopsy. It measures different genes, one of them called P10, and this is linked to an aggressive type of prostate cancer. It gives you a score, a genomic prostate score, and again, this tells you more about, do you truthfully add up to a guy with low risk or intermediate risk based on the genetics. This is a lot more objective than a guy looking under a microscope at your cells saying, hey, this looks pretty low risk. I think I'll just assign him a Gleason 6, which is what they essentially do. So this is for men with low or intermediate risk, not for men with high risk. They run 17 genes in analysis, and they give you a score between 0 and 100, this genomic prostate score. So these are all the kind of genes that they run. They run some that are associated with benign cancers, some that are associated with aggressive cancers. And this is an example where 2 men came in with their biopsies that were basically in the low risk group, because Gleason 6 men. They ran their genetics. One came back very low risk, so he was very happy to do surveillance. Another came back intermediate risk, so he thought twice about being on surveillance, and he started to consider what kind of treatment he may need. So again, this is a kind of example of a score they give, this GPS score, that says, my gentleman who came in Gleason 6, his genetics look even better, even lower risk, so he's going to feel better about potentially doing something like surveillance. The likelihood that he has very low risk type pathology, again, 84%, based on the genes from his biopsy specimen. So the third type of test, which we've run in our clinic, is called Decipher. This is a test that predicts what's the chance of you having metastases at 5 years without treatment. And then again, like the previous test, Polaris, what's the chance that you may have mortality or die from prostate cancer without treatment in 10 years. It gives you ideas as to if you're a good candidate for surveillance. It gives you ideas if you may be able to get away with local treatment, whether it's radiation or surgery or any kind of other local treatment as well. Or it tells you if you have an aggressive type of DNA change, you might want to think of multiple types of treatments, hormones, radiation, chemotherapy, all of these things. So this is an example of a test that came out of a gentleman, and he had a Decipher score that was very low risk, and it said basically what's the chance that will have metastases at 5 years? 1%. What's the chance that he may die of his cancer without treatment in 10 years? Again, 2%. So it gives you this data in a different kind of diagram to give you better reassurance or more clarity of how to pursue your treatment. So this is very new as well. This is a very, very new thing from this company, which is interesting. It's not quite ready for prime time, but it's basically the same company, Decipher, with all the genetics that they run on analysis. It actually prints you out a whole grid as to what's the chance that you're going to respond well to hormone therapy, what's the chance you're going to respond well to radiation therapy or chemotherapy. So based on the genes, it tells you what kind of prediction you may have. If you're doing hormones, is it going to work really for me? Are you going to do radiation? Is that going to work really for me? So these are new things that are pretty interesting in developing that we can use to integrate for patients that haven't done treatment, that are looking into options. So another question that we have commonly for our patients is those with advanced cancer. So men that have metastatic castrate-resistant cancer. They've been on chemotherapy drugs like Taxotere, Gevtana, hormone therapy drugs like Zytiga, Xtandi, or radiation drugs like Xofigo. So the next kind of question is, are there any other types of tests I can run on my cancer DNA? So there's 2 other kind of tests we run with our patients. One is called Foundation 1, and the other one is called Garden 360. These are molecular tests. These are tests that are run on blood samples. One's run on tissue, which I'll get into. But this one, for example, is the company called Garden 360, which is a local company. They take your blood, like a regular blood draw, and they analyze the actual tumor DNA floating around invisibly in the blood. And they analyze for circulating tumor cells, the DNA linked to that. And then they sequence all that DNA and they look for mutations that might give other options for treatment outside of standard options. So there's a whole panel of the genes that they run through this test. And they give you this really sophisticated printout that tells you, hey, this is my patient, and we ran this whole library of genes, and it came out with 3 different mutations. And it turns out that this prostate cancer patient may respond to a lung cancer drug, or may respond to a kidney cancer drug. So it's giving you other options past the tried and true chemo and hormone type of therapies, and what may be of benefit. The other test in the same kind of categories, that one I mentioned before, Foundation 1, the difference is the previous test, Garden, runs on blood. This test, Foundation 1, which has been around longer, is run on tissue. So you have to give a tissue sample from a biopsy of the prostate or from a metastases. It runs a lot more genes, over 300. But again, it's supposed to basically identify other kind of off-label treatments that a patient may respond to. And it even identifies other clinical trials that he may qualify for based on the mutations. So again, a lot of genes, a lot more than any other genetic test. And this is kind of a sample report for this patient who ran his analysis, and they found these mutations, and they found this man would actually respond to a kidney cancer drug, and there are other clinical trials across the US that he can look at participating in. Again, this is just an example of different trials. It gives pages of these kind of printouts in terms of the analysis for other data that you can look into that are available throughout the US. So Foundation Act is part of the same company, Foundation 1, but this is a blood version of that. It just runs on less cells, runs through 62 genes, but this is valuable for patients that can't biopsy a spot in the bone or biopsy a spot on the spleen or the liver. So this is much easier, but it just analyzes less genes. So why am I talking about all these things with these genetic tests? The reason being is late in 2015, a big report came out in New England Journal that showed that men who have a certain breast cancer gene mutation in their prostate have a huge response to other kind of drugs that are available. So this was a big report that came out in late 2015 that showed there's a ovarian cancer drug, which is called a PARP inhibitor or olaparib. And basically patients with a certain mutation in their cancer DNA had almost a 90% response to this pill. This is not a chemo, it's not a hormone. So these just open up more options for patients looking for less conventional type of treatments that are not chemo. I just want to mention a little bit about genetics, hereditary. A lot that I've talked about is kind of about pre-diagnosis and after diagnosis and metastatic, but germline mutations are the mutations in the genes that we give off, that we give down to the next generations, we get down to the kids. So the biggest two mutations that we have in men with prostate cancer are BRCA1 and 2. This is a breast cancer, ovarian cancer gene. Again, 40% of women with this kind of genes will end up having ovarian cancer, and 45% with this will develop breast cancer. And this is much higher than the conventional population. So these are genes that are huge factors in prostate cancer, and that open the door to other kind of treatments. But for men that have these mutations, they have to seriously think about other family members and having their kids screened. Patients that have these kind of screening tests are patients that have a lot of other family members that have different cancers that are very young. Your guy that has prostate cancer at 42, he has a sister who had breast cancer at 36. These are the kind of people that need to get these tests run so they know what the implications for their kids could be. But for the differences, germline is what you pass on to your kids, and somatic is the kind of cancer mutations that we've been talking about. So men that have these mutations on their cancer DNA respond to these drugs like I talked about, this ovarian cancer pill, and different kinds of chemotherapy than conventional. So it just gets us to the point where we can better hone what we're doing and better investigate what the treatment options may be. So this is kind of a little diagram of the most common mutations in men that are hereditary. Again, BRCA1 and 2, and a couple other ones, ATM and CHEK2. So again, just kind of as a quick summary, we've talked about tests that we use before the diagnosis, these blood tests, prostate health index, 4K score, exosome-DX, patients who've had biopsies done that are looking to kind of figure out if they can be watched and need treatment, Prolaris testing, Oncotype testing, and Decipher testing, and then tests that are run on for patients with metastatic cancer that are looking at other options. These are the Guardian 360, the Foundation 1 test, and the Foundation Act test. And that's about it.
Can you go back that last slide?
Yes.
Okay, Dr. Turner has talked about a lot of things here, and a lot of you come to my sessions over there, and we didn't talk about a lot of these things in my sessions because these genetic subjects that he talked about are a little beyond what I talk about. So I'm sure that there's some people out there that have some questions. Anybody has any questions? I'll pass you the mic and you can ask Dr. Turner.
These tests that you just had on the last screen,
Yes.
the Polaris and what is it, Decipher?
Decipher, yes.
Yeah. So do local urologists have the ability to have you get these tests, or do we have to go to a special place where they do these kinds of tests?
They do have the ability, it's just most of them don't invest the time to know that they have that ability. So most average urologists won't know much about these tests. I'm sure if you bring that to their attention, it depends on how proactive your urologist wants to be, or it depends on the patient.
Okay, so if I go to my urologist and mention these things, he
Right.
has the ability to make sure that I can get these kinds of tests.
Right, and if not, he may say, oh, that's not worthwhile, but then you have to say, hey, I heard about these tests, these are valuable things I want to check out, and these are pretty inexpensive and might give me more information. Then it's the kind of sheds light if that's...
Rather than a biopsy.
Right,
Yeah,
exactly.
something other than a biopsy, these are options.
Right, and part of that is not that urologists, urologists are good physicians too, but I think a lot of them are very, low threshold for biopsy, right? So you can use these tests prior to doing a biopsy to give you better information, which some of them feel it's taken away from the business.
And you just need to know what the names are. If we go on and Google these things, they'll come up.
Exactly.
Hi, Dr. Turner. First of all, thank you for this presentation. Excellent information. For me, I was caught with some interest in your nutritional rundown at the beginning. You mentioned aspirin and particularly dairy. Would that include all dairy, such as cheese, butter, milk, and that sort of thing?
Yes. Yes.
I love those things, but do you have suggestions for alternatives like soy milk or almond?
Right, so a lot of our men will drink almond milk, soy milk, so all those are very fair and fine substitutes, as long as it's not traditional whole milk, yes.
Thank you.
I might add to that you can, if you like your eggs, just don't eat the egg yolk. Go get egg whites at the grocery store or egg beaters, and you can do that.
Thank you.
And also Google Mediterranean diet. The Mediterranean diet will tell you what you can eat a whole lot more than just these couple little things.
Yeah, thank you for your presentation. My question would be, although it's kind of you don't like to look at it this way, but have you seen any of your patients, or has the company that produces these tests shown any that have been higher than, say, that looked like about a quarter of the way up or maybe a half? Have they been able to detect, unfortunately, some people with the arrow is closer to the 100% there?
Definitely. I've had patients.
You want to make sure it works.
Right. I've had patients that had scores on those kind of estimates that are in the 0 to 1% range, and others that are higher than 95%.
The other quick question is, the Guardian 360 there, would that be applicable, depending on, of course, the patient, for someone who has had a relapse with radiation, and where it looks like the retake of the cancer was related just to the prostate area? Would the Guardian 360 be applicable in something like that?
So you're asking for patients that relapse after radiation, that will relapse locally?
Yeah, and don't go to the bones or...
I mean, I don't think, it probably doesn't apply so much in those kind of fashions, because you try to look at other local therapies to get you cured. There's nothing wrong with getting that data, but I probably wouldn't look there for my first.
It would be sort of meaningless, or you're saying?
Yeah, I mean, I think a lot of these tests, you can get the information, but for patients like that, I probably wouldn't look so much to that test. These are more intended for patients that are, metastatic and have already gone through a lot of the therapies. What else can we do?
Thank you.
Dr. Turner, on the, I think the second from the last slide where you had the grafting 1 and grafting 2 genes,
Yes.
and I think it was a comment said that there was a 45% of getting breast cancer. Is that for women or?
Right. No, that's just for women. That's just a stat saying that this is obviously a high risk for women that have that. That's not for men. But for prostate cancer, it's still part of, I didn't give estimates based on the prostate, but that's strictly for women.
But men do get prostate cancer, I was told.
Yes. I mean, those people that have those genes do have a higher risk of getting prostate cancer. Yeah. No, they do, and men can have breast cancer with those mutations, but not with those statistics. So the 40-some-odd percentage was just strictly for women, whereas for men it would be a lot lower probably. I mean, most men in general population that get breast cancer is less than 1%. With those genes, you're looking at closer to 10%.
I see.
Yeah.
Okay. And then do you know anything about the ARV7 test?
Yeah. So ARV7 is a test on blood cells to look for this variant to the androgen receptor that predicts that you may be better treated with chemotherapy than hormone therapy, right? So this is a blood test that right now is run through Johns Hopkins that you can get sent off to your local oncologist or somewhere to run that with a certain fee to look at these tumor cells and see if you have that variant of the androgen receptor that predicts you might be better treated with chemo versus hormones.
Okay, thank you.
To do the ARV7 test, to probably do that if you fail to Zytiga or Extended, right?
Right, especially early. We're never got a response from one or the other.
Anybody else? Okay, I'm going to ask something that's kind of off the wall a little bit. I have stage 4 metastatic disease. Why has my doctor not recommended any of these tests?
Because they're not specialists in prostate cancer. To be honest, I think that's our job, is to know what all the new technology is and all the cutting edge tests. So I think if you go, and there's, obviously most of us that get trained through oncology are general oncologists, which is not what we are. And they like to, see their patients in under 10 or 15 minutes at a time. And they don't want to go to that length because they're treating so many different people. They can only have so much of a knowledge level. And this is not as in-depth as it gets for this.
But bear in mind, my doctor is Dr. Turner.
So you're talking about your specific case?
Yes.
Yeah. So this is in your kind of case, it depends. because you've been responsive so well so far for so long that unless these are usually opened up in cases where you have progression of cancer, rather than let's just do it to see what comes out. Because then part of the worry is if you run these tests when a patient's doing well and you find a target and you say, well, throw out what you're on because this looks interesting, then patients may develop a poor response to going back to that same therapy that worked. They may try to concentrate on something that may not work. It's not a guarantee.
Okay, the reason I asked that question is because we all want to know, should we run out and get these tests? And I'm the perfect example of, with metastatic disease, if they were given generally, I should have. He answered the question, no, not unless there's something happening to you.
Thank you. Question number 2. Just thinking about things like race for the cure, my mind thinks, well, what about the cause or causes of prostate cancer? We drink a lot of coffee, we get things from all over the world. Water ranges from really good to traces of things like arsenic and other things. Is there any trend line or chemical line in terms of what we drink, consume, etc., that could lead to perhaps causes for prostate cancer?
In terms of great data, there's not, unfortunately. So as far as like drinking products and things like that, there's not a lot of good sound trials that show that we can actually delineate specific elements within the water that we drink or different kind of things that we go through in our day-to-day diet that have a huge risk in that kind of means. I mean, I have patients myself that come to me and they go through like chelation and different things because they're looking at their whole parameters saying, hey, I went to my naturopath and he ran all these elements on me and I'm doing chelation for, mercury and all these different levels. But the reality still is there's a lack of data for prostate cancer, at least for a source and what to eliminate based on that. I don't frown upon that, but I don't know as far as data that's robust enough to dictate, hey, you need to go get all these kind of elements checked out and look at for you.
Let me give you an example. If I worked in a building that had the Prop 65 warning notice, warning materials may cause cancer, other reproductive harm. Well, the prostate's a reproductive organ. So I thought, well, what's in this building? And I went on the state's website, and there's like 8,000 or 9,000 chemicals that could constitute the requirement to put that sign on the building. I thought, well, how could you ever test for all these chemicals? Is it from the carpet, the underlayment, the water, the landscape people that are putting pesticides? I mean, it's sort of mind-boggling. So are there any thresholds that bring those signs into our buildings, whether it's legacy construction, non-LEED certified new buildings? Or is there anything out there that could say, well, hey, a person works in this building, they have that risk for prostate cancer, or any other type of cancer?
Right. I mean, I think that's a fair question because a lot of our patients, like for example, I see a little different from what you're questioning, but I do see a lot of patients of mine that have gone to the VA and had different exposures, an Agent Orange exposure. Obviously, it's a very different kind of parameter, but these are things that we know are carcinogenic, and they can apply a whole way across, and not just prostate. You can have all these risks for different lung cancer and bowel cancer and all these other kind of things. So I think part of it is just the fact that, from a quality control point of view, people have to be doing a better job that applies on the wider net of things, which they don't do, unfortunately. Like you're asking, with new construction and these things, I don't think they're doing as good a job as they need to be able to catch these kind of parameters. I think they're more focused on product and getting people in there and using what's built rather than all the safety regulations. They have certain baseline regulations, but unfortunately they don't delve deep enough into that.
Just wondered your opinion on Provenge. I don't know, maybe I missed it. I didn't hear if you mentioned that or not.
Right, so Provenge, right, a little bit different from the genetic point of view, but Provenge is essentially the only FDA-approved immune therapy for prostate cancer. It was approved about 2010, and essentially, basically, it's a patient giving off his own white blood cells at a red prostate location, them incubating them with a protein for prostate cancer to kind of smarten up your white blood cells to fight, basically a more judicious fight against prostate cancer. The reality is this is really intended for men that have metastatic and hormone-resistant type prostate cancer, but that's very slow growing, and they don't have many metastases. So the reality of this kind of therapy is it's a good immune therapy, but it takes many, many months and years to get up to speed. So I wouldn't offer this kind of therapy for a gentleman who has rapidly growing metastatic cancer because he's not going to get the benefits because the cancer's going to outgrow the time it takes to actually develop benefit from the immune therapy. So in short, this kind of immune therapy is good for men that have a few metastases, their PSA is very slowly rising, and then over many months, they'll end up getting a better immunity to this and then fight naturally.
How do you evaluate the metastatic cancer evidence based on MRI and CT scan compared to PSA, rising PSA?
As in, like, is there a certain threshold that we end up scanning patients? Or?
Well, what do you think is a better indicator of overall prostate cancer?
I mean, in terms of the patients that are developing metastases, that potential, or?
Yeah.
I mean, in general, we always take factor in PSA as part of the equation, but I would never use that as the sole kind of indicator. So for patient, basically we'll do things like bone scan imaging, CT scans, MRIs, and they come out with a lot better imaging now today. They have a lot of these sophisticated PET scans that are whole body PET scans that you can do for a new diagnosis of prostate cancer, or you can do for a relapse of PSA after surgery or radiation. But these are, certainly right now, these aren't covered by insurance, but they are done in many places, Southern California, UCLA, for example. Some of these scans are being used for brand new diagnosis of prostate cancer because they're so much more accurate than conventional bone scans and CAT scans. So these are all factors as part of the equation. So for me, I use PSA. I use another blood test called alkaline phosphatase, which is ALP. That's a blood test that's elevated in men that have bone metastases. And then I use things like bone scans, CAT scans, MRIs, and then I'll talk to patients if they get into these newer sophisticated PET scans.
What is someone, at the meeting today, someone mentioned AXUMIM as a scan. What is that?
So that's one of these actually brand new PET scans that was just came out basically December of last year. So this is a scan that's intended right now, this accident scan is intended for men who've already been treated with surgery or radiation and then they've had relapse of PSA. And this scan is much more sensitive to find where your relapse is than a conventional bone scan. So for example, men who had the surgery, the prostates were removed, and their PSA is only 0.2, you can do this scan at a PSA of 0.2. And conventional bone scan, you're never going to see anything. For conventional CAT scan, you're not going to see anything because everything on a CAT scan is only abnormal if the lymph nodes are really, really large. These kind of tests, they end up looking at uptake and how bright different things are. So they're much more sensitive, but Axumin, unfortunately, is only covered right now by Medicare. But it's a nice option for patients to use.
But this would not be recommended for someone who hasn't, the cancer hasn't spread, it's still
Correct.
contained, so this would be more of a scan for someone with advanced.
This is more intended essentially for patients who have a relapse of PSA after already having local treatment, and it's not for newly diagnosed.
Anybody else? Well, that was very comprehensive. And, from what I discuss in my meetings over there, I don't go into all these genomics over here that Dr. Turner's gone in. So this has been very educational for us. Now, I know you got lost, Dr. Turner, and you used up a lot of your time. Did you really leave Marina Del Rey at 4 o'clock?
Yeah, I went home first, honestly.
Oh, okay.
I didn't come straight here for 4 hours.
Oh, okay. Because he was asking me the other day, he says, well, if I leave the office at 4 o'clock, is that enough time? And I'm thinking, 4, 5, 6, 7, yeah, you'll be here. I kept looking for you. I was going to get to you. So you went home for a little while. Okay, that's
I was just trying to get let out of clinic earlier, that's the
Mark will let you go early.
Yeah, exactly.
Okay. Well, I know that you're very, very conscious of time because of all this, and we can't give you any money, but we can sure save you time. Here's a coffee cup with Prostate Forum on it. Instead of having your coffee at home, you can set it in your car and drink it on the way to work.
Perfect.
So,
Thank you.
thank you very much, Dr. Turner.
Thank you for watching our video. If you would like to learn all the most current prostate cancer information, we have many YouTube videos on our website at www.prostateforum.org. We also have meetings the 4th Thursday of every month where you can talk to mutual survivors. You can also ask personal questions to the doctors and the speakers after the meeting. Remember, when us men hear the word cancer, the big C, our brains turn to mush. We think we're about to die. Come learn where there's hope and information at the Prostate Forum of Orange County.